On today's episode of the Dr. Tom Show, I'm joined by an implantology expert, Dr. Charles Schlesinger. He's the VP of Product Development for Impladent LTD and Solmetex. We will discuss bone grafting techniques and materials used for socket preservation and implant site development. We will also discuss the reasons dentists choose particular grafting materials and techniques, as well as some of the incredible technology that's been available to us for many years. I also want to get an answer as to why implant companies frustrate us with so many different screwhead shapes. And finally, do we have an impending crisis in the implant parts category, as so many different designs exist but are often discontinued for the latest and greatest? The Dr. Tom Show starts right now. Chuck, thanks so much for being here with me today. I really do appreciate your time. I know that this year you're celebrating 30 years since dental school graduation, so congratulations on that milestone.
Thank you.
You've always been, in my mind, an implant guru. I mean, that's how I've always associated your name in various ways, whether you're teaching courses, working with different companies. And I wanted to start by asking, do you remember your first implant, the first one you placed, and what that experience was like?
Yeah, I actually do. It was about a month into my second residency at the VA in Los Angeles. And my attending said, "Hey, we've got a patient. We want to do an implant. It's a number 8. Would you want to do it?" And yeah, it was terrifying. It actually was. Trying to remember everything. I was just really learning about implants at that point because we didn't have much implant education in dental school at all. Yeah. My first residency in San Diego, we really didn't get much as far as implants education. The only implants that I saw were blade implants that I was taking out surgically. But yeah, it was interesting. It went well. It was a very cumbersome process because of the system, and we're talking about 1996 and 97 at this point. But it integrated. It was restored, and it was my first success. So yeah, I do remember it.
That's fantastic. And how long would you say it took before you really fell in love with implants? In other words, you do a few, you have some ups and downs, but obviously implants has become a big focus point in your career. Where did that switch click for you, where implants were really a thing?
I think it was pretty quick. It was pretty quick. And it was during that residency year that I was really exposed. We had to, at the same time, we took the implant continuum at UCLA at that point. And so it was really nice. And it was a very extensive and overwhelming program, but it made me realize that this was the future.
Yeah.
And it was very different from the restorative dentistry that I had been taught in dental school. And I always had loved surgery, and this was a way to combine surgery with restorative dentistry in a way that to me was very fun because it allowed me to do both. So I have to say I was pretty hooked early on. It took me a little while to get it once I graduated, to get it going in my practice, just due to this kind of the situation of, at the time, being a general practitioner, trying to do implants. Implant treatment was very expensive at that point, and it was absolutely not covered by insurance at any level. So it was hard. We had most patients that would literally come back and say, "Well, I've got an option between an implant and a bridge. What does my insurance pay for? That's what I'm going to do." It took a few years to really get my feet on the ground, and that was probably a good thing, though. It allowed me to do some continued education also.
And work your way up. Mm-hmm. The evolution of implants certainly continues, but over the 30 years you've been doing them, where do you think the biggest changes have happened? Is it in the design of the implants themselves? Is it the techniques we're using to place them? Where is it we've made the most advances? Because obviously implant dentistry today far more accepted than it was 30 years ago. Patients are even bringing it up when they come in and they know they have a tooth that needs to be replaced. They say, "Oh, can I do an implant here?" So
Mhm.
where have we made the greatest gains, do you think?
I mean, from the acceptance side, it definitely came from just more patients having implants, having it become more of a known type of treatment to the general public. So they started to come in and ask for it. I think from an implant side, I think systems have become more straightforward, simpler. I think we understand the concepts better. And then minor changes that occurred going from untreated surface implants that were just machined to various types of surface treatments that help enhance integration, decrease the healing time, and make it more predictable. I think advances in definitely restorative connection, I think
Yeah.
has really probably to me has probably been the biggest thing because implants will integrate. Anything made
Yeah.
out of titanium will integrate, but it was always from a restorative dentist point of view, how do we have a system that's predictable and easy and connections that don't cause bigger problems for us. Many of those early connections, as you know, were problematic and you do everything right. And then all of a sudden you have a prosthetic failure and you're like, oh, and then that usually led to possibly bone loss around the crest of the implant. And then it was just a cascade of problems from that point. So I think our predictability got better. I think it definitely was design of both the implant on both the macro and the micro levels, and definitely better prosthetics and a better connection when we moved from butt joints and external connections to internal
Yeah.
connections.
And you're recently, again, congratulations are in order. You're the VP of Product Development for Impladent Limited and Solmetex. Yes, that
Yes.
started
Yep.
this year, I believe. But one of the products from Impladent, Osteogen, is something you were experienced with long before that. Tell me how you discovered that product.
Yeah, it came about as I was trying to investigate different alternatives to traditional grafts and traditional grafting materials.
Yeah.
I was brought up in the time when we used bovine bone for
Yeah.
everything. And then I made a transition from bovine bone to more allograft particulates, just due to the amount of time that it took for bovine bone to break down and be replaced if it was replaced at all. And so then it was as I continued on my own education and my own clinical experience, I started to see the downfalls or the pitfalls that I was running into using particulates and came across the Osteogen composite products around 2000, between 2013 2014 was
Mhm.
really when I got exposed to it. I actually had reached out to the company at that point and got lucky enough to do some beta testing with some of the new products. And I really just saw it as a big leap in my
Yeah.
efficiency as a dentist and what I could do. And so from there, I just continued to use the product over the years. And as new products were introduced into the line, I really tried to push the envelope. That was something that I really like to do clinically.
Hmm.
See how far these materials, whatever it might be, can
Yeah.
go before I start seeing effects that are not good. Not obviously not as an expense to the patient's expense, but it's always a calculated risk, and
Sure.
I can see how things go. But yeah, it was exciting to find something that worked efficiently, worked predictably, and really made my life a lot easier.
And one of the things about this particular product is this bioactive crystal technology.
Mhm.
And how does that contrast with allografts and xenografts? In other words, how can we kind of organize those different bone grafting options that we have available to us today?
Well, I think when we look at grafting materials, particulates, whether they be xenografts or allografts or other alloplastic materials, the majority of materials out there are really only osteoconductive, meaning that they only producing or providing a framework for new bone growth. Um, some of them are, depending upon the formulations, do interact a little bit more with the body. But with the bioactive crystal technology, what that really means and where it differs is that the crystals were designed from the very beginning
Mm-hmm.
to interact with the body in a positive way. One of the ways is that the actual physical form of the crystals is what we call biomimetic, which it replicates a natural tissue. And if we look at it from a microscopic point of view, it looks very much like cancellous bone in physical structure. It is manufactured in such a way that the with this biomimetic form, that bone will actually attach directly to the crystal. And then as the crystal starts to get broken down and replaced, it is now also giving off ions into the general area where we're regenerating bone. And what that is doing is that is providing things like hydroxyl groups and calcium and also phosphate to basically allow the body or give the body all it needs to try to regenerate and
Yeah.
regenerate itself with a not an increased speed, but a more efficient way. When we look at some of the other materials that are out there, and especially if they've been manufactured in certain ways under high heat, we end up with a situation where it's very difficult for the body to break those down. So the crystals work with the body in order to regenerate bone. One of the other things with bioactivity that we talk about is in the composite grafts like the plugs and strips and block, that the combination of the crystals and the type 1 bovine collagen, as it's compressed into the site, creates a framework basically that acts as a barrier. And so that's why in many cases with just routine socket preservation where we have intact walls all the way around, we're able to accomplish grafting without an additional membrane or barrier
Yeah.
and really influence the soft tissue to grow across to epithelialize rather than trying to dive down into the graft.
And are there still times when a membrane would be appropriate? Are there
Absolutely.
particular scenarios where you would still use a membrane?
Yeah, in my hands, and what we also recommend is that if you're missing hard tissue, meaning you've got an extraction site that has a large dehiscence, maybe due to a vertical fracture or endodontic lesion or something, if you're missing part of the crestal bone, then we recommend kind of a belted suspenders approach using
Yeah.
both the osteogen material and using a some type of resorbable membrane. In most cases, some clinicians like to use non-resorbable. But what we want to do is we want to give ourselves the best opportunity to regrow that lost tissue. And therefore, by keeping the soft tissue and the hard tissue separated with a membrane, we're able to accomplish that, as opposed to a particulate where a membrane or barrier is necessary to
Yeah.
prevent migration. Migration doesn't really happen with these products because of the product is crystals incorporated into collagen network already.
Yeah. And I think that simplicity is really one of the things that rang so clear to me as I was looking at this product. Take me through Take me through the starter case. I'm new to socket preservation. I'm getting ready to take out a number 30 next week, and I want to do a socket preservation procedure simultaneously using osteogen. How does that go?
So pretty straightforward. I mean, obviously, we want to follow all the tenets that we can of atraumatic extraction to begin with.
Yeah. Yeah.
There's lots of ways to take out teeth. We can be very destructive to remove teeth. So we want to try to preserve hard and soft tissue. So the first thing that we're going to do is with multi-rooted teeth, I always recommend sectioning those teeth first.
Yeah.
Coming in with a surgical handpiece, section those teeth. So now you're taking out two single rooted teeth, much easier to do. It
Yeah.
also negates any problems that you might have with either dilacerated roots or roots that are converging at the apices, where you try to take it out all in one piece and you end up fracturing off, the bottom third of the root. And now your 15-minute extraction becomes a 45-minute nightmare.
Exactly.
So we try to avoid that. So once we get that tooth out and we take our time and we remove that tooth, now we want to come back. And a really important aspect to using these materials is getting a good blood supply. What we're trying to do is we're trying to tap into what is called a regional acceleratory phenomenon, which means that we're damaging the tissues just enough to stimulate the body to regenerate. So it's very important with especially osteogen plugs to get in there and really decorticate the socket. So we want to get in there with either sharp curettes, like serrated curettes, or with degranulation burrs. We can go down in there, remove a portion of the lamina dura to get active bleeding. Really very important. And what I consider active bleeding is that socket fills up with blood. You come back in with a suction, you suck it dry, and within 10 to 15 seconds, it's already filled back up.
Okay.
That is what I want to see.
Yeah.
Once I see that, now I can come back and I can do my graft. And so I can open up a package of a blister pack that has an osteogen plug. They come in various sizes. Usually large plugs are pretty much the go-to for most situations, but it's also available in slim plugs and in extra large plugs for very big sockets. And then what I usually do is I will then take a suture scissor and I will cut from the apex of the plug up maybe halfway. And then I can separate the bottom of that plug out into basically two roots and then slide that in. So we take that dry plug, we slide it into the socket. As the blood is constantly flowing, it's going to saturate that plug. It's going to make it malleable. We're able to push it down. Once we get it down, then we can use an instrument, whether it's a bone plugger or the back of a curette or the back of your periosteal elevator, and just really tamp down the top of that plug. We don't need to push it all the way down to the level of the bone. It can be somewhere in that soft tissue area. That's completely fine. But we want it to be solidly tamped down. If the socket is extra large and you used a large plug, then you might have to add some more material to it. But once we do that, then it's essentially just putting a figure eight suture over the top to make sure that plug doesn't move, keeps the soft tissue from flapping around, especially if the papilla happen to be torn. And then normal post-op instructions for the patients with regard to gauze, what they can do, what they can't do. It doesn't really change from a conventional extraction. Post-op medications, pain medication, and an antibiotic. And then we usually see them back in about 2 to 2.5 weeks for suture removal. At that point, we can remove the sutures. We usually have a decent amount of the sockets been epithelialized at that point. It's going to take a couple more weeks for it to completely close over. And then we let that patient go. And if they're thinking about an implant treatment somewhere down the line, we'll usually bring them back in somewhere between 3 to 5 months and take a conventional PA to see how that graft is turning over.
And so that's another question I wanted to ask you. The visibility of this on x-ray, how is my x-ray looking if I take a PA the day of placement versus that subsequent follow-up x-ray? How am I seeing what's changing there?
So that's great. When these materials go in, the osteogen crystals and the combination osteogen crystals and collagen graft, when it's in the site, if you were to take a PA at the time of placement, it would look very radiolucent when comparing it to the adjacent bone. And that's just due to the structure of the graft material. As the body is replacing that graft material with native bone, we're going to see the radiopacity start to come up and look much closer or completely just like the bone that's adjacent to it. So this is a really nice thing because other grafts that are out there that are much more dense, it's very common, for example, with either high density HA or with bovine material, you place that in a socket, it looks very radiopaque. And it's really difficult, even 4 or 5 months down the line, it still looks very radiopaque. So there's no way to know if you've got bone growth or you still have graft material that's sitting around. So we kind of incorporate that into the way that we get the patient scheduled. Like I said, we'll do the extraction. We'll bring them back at 2 to 2.5 weeks for suture removal. We usually are not taking a pre-op x-ray, but I recommend
Right.
if you're first starting out, do it just so you
Yeah.
can see what the difference is. And then like I said, about 3 months, we usually will bring the patient back in, shoot a simple PA. That tells us if we need to wait a little bit longer for
Hmm.
things to turn over or not. If I see a situation where it looks like that the graft has been replaced with bone and that radial opacity is equal to or very close to the adjacent bone, then we get ready to move them into the next step of treatment, which would be an implant placement. We'll take a cone beam and just see what the volume is and get ourselves ready and set them up for an appointment.
Yeah, very nice. In addition to kind of seeing is believing with an X-ray,
Mhm.
you this is also a very well studied material. I'd like you to speak a little bit. One of the things I see most often, I think, is called the Jones study, where they showed 6 times greater osteoblast proliferation in sites with the osteogen plug. So, talk a little bit about the science behind why we see that transformation on X-ray.
Yeah, so it's all about bone growth, and it's in order to have a consistent and good bone growth, you need to start out first, obviously, with the migration of osteoblasts into the site. That really, without that, nothing else is going to happen. The body, the human body, like it does with most things, it throws a lot into a situation and then really kind of culls it down. In the situation with a socket or bone graft, basically you're getting millions of osteoblasts that are flooding into the site, and maybe only 15% will become adult bone cells later. So it needs to supersaturate with osteoblasts. They have to migrate in. What the Jones study did is, which was really interesting, is they took multiple substrates, everything from collagen to osteogen to allograft and bovine bone. And then what they did is they seeded these plates basically with osteoblasts that were impregnated or had contained a bioluminescent marker. And then what they did is they basically let them go for a 10-day period of time, taking uh, basically photographs of the bioluminescence to
Hmm.
indicate how much proliferation there was. And what they saw was collagen, obviously great substrate, right? So osteoblasts were very good on that. The osteogen material, very high proliferation. The allograft, moderately high proliferation. And actually, the lowest proliferation occurred on the dense bovine bone.
Yeah.
And so the study concluded that because of the physical structure of the osteogen material and the activity of it, that it was a much better substrate than a dense material like a bovine bone or even some allograft materials. And so what they concluded was that the osteogen material was a much better substrate for proliferation of these osteoblasts, and therefore in vivo we're going to see the same thing. And so that was
Mhm.
very interesting. And it was, like you said, it was about a 3 to 6 times increase in the amount of proliferation on the osteogen when compared to the allografts and the xenograft.
And this has something to do with the centered versus non-centered particles,
Yes, yes. So I'm
because
glad you
that's
kind of brought
another
that up.
unique.
Yeah.
Yeah, that's another unique aspect that I was reading about.
Yeah, so a lot of materials out there are sintered or manufactured under high heat or treated to a high heat. A-chain materials, a lot of them are treated with high heat in order to create a better particle
Yeah.
from a physical structure. Bovine bone, for example, is treated under high heat normally in order to decrease its antigenicity and decrease the possibility of immune response against it.
Yeah.
So those are the reasons they do it. The problem is when you subject calcium phosphate or HA to high heat, you chemically change it into a ceramic. And a real easy way to think about it
Uh,
is I've used this analogy before with people. You go to paint your own ceramics and they hand you a coffee cup that's white, it's chalky, and then you paint your masterpiece on it, you give it back to them, and then it comes back in 2 weeks and you can now drink out of it, and it's hard.
Yeah.
Well, what they've done is they've taken it, put it in a kiln, essentially sintered it, and
Yeah.
changed the physical structure of that. So where that affects graft materials is, one, when you sinter, it becomes very dense. That density is what we see on an X-ray when we see it
Right.
being very radiopaque. The other thing that happens is by sintering, you force the molecule to hold on to all of its parts very tightly. So
Yeah.
it doesn't want to share ions as easily. And then what that results in is the body has a very difficult time breaking down a very dense ceramic like that.
Yeah.
And so in the normal breakdown of bone, and the remodeling of bone, we have osteoclasts that are responsible for that, and they'll do the job that it needs to do. With the osteogen crystals, because they're manufactured under low heat, their crystal structure is very highly microporous. Then what happens is that osteoclasts can actually break those down. So the crystals get disseminated and broken down pretty easily. With the sintered products, what then occurs is the body throws osteoclasts at it. It might break down some of it, but then has a very difficult time after that. It then recruits in macrophages. The macrophages then go to work, right? Which is good. Macrophages are very good for the situation. They're going to increase the inflammation a little bit. And then at some point, if they can't break themselves down, then they recruit more. And when you recruit a whole bunch of macrophages to try to do it, you end up with a situation where you have giant cells. And then these macrophages don't change. So in a best case scenario, what happens is you have the first type of macrophage, which is an M1 macrophage, and that is going to start work. It's going to increase the inflammation. It's going to start the breakdown, and then it's going to convert into what's called an M2. That M2 decreases the inflammation and then clears out the product. In situations where you don't have that conversion to an M2 because nothing is happening, you have a lot of inflammation, and then you get the body's only way to defend itself against this is by encapsulation. And so we see that a lot with these dense materials, that on histology, you see these chunks of material with a coating, essentially, of connective tissue. And in many of these cases, these never break down. Or they take so long to break down. And the problem is that you come back to a site, let's say 4 months later, thinking you're going to place an implant in there. You open up the site. Sometimes you look in there, you still see unincorporated particles. But let's say that you see it and it looks pretty much like native bone. And you drill into it and it's hard. And then you drive an implant in and you get good primary stability. Things integrate. Then you come down to your restorative phase months later, you restore it. And then the thing that can happen is 6 months later, 2 months, 2 years later, all of a sudden you start to see massive bone loss around the implant, or the patient comes back and says, hey, you know what, this thing's hurting. And before I really dug into this aspect of it, I always just chalked those up to, I have no idea. Right.
Yeah.
It was a perfect surgery. Your oral hygiene's great. The prosthetics are good. I have no idea why this failed. And what I started to think about was maybe it's this situation where you have a high percentage of connective tissue. And there's been a multitude of studies that have been done not only in dental and in orthopedics that have looked at this, that you can have up to about 60% of your graft remaining as connective tissue down the line. And so, as you can imagine, now you've got a situation where you have an implant that's in basically a construct of bone, connective tissue, and chunks of unliving tissue. And all of that connective tissue allows for flexibility. Right, in the bone. So we know that natural bone has flexibility, and we know that a tooth obviously has the ability because of a periodontal ligament. usually does not. We're probably looking at less than 5 microns of movement just from the collagen that is in bone. But now maybe it's a situation where this implant is able to move more. And maybe now we end up in a situation that once that implant is loaded, the implant is able to move laterally 100 microns. And we know that when you have movement like that, the body's reaction to that is to throw soft tissue in there.
Yeah.
And right. And now you end up with a situation where as they continue on and more soft tissue is in there, you get more movement of the implant and it ends up just going downhill from there. So these are kind of things that I started to think about and started to think, well, maybe there are problems with some of these other products. And I think that the more complete that we can regenerate bone and the more that we can harness the body's ability to make the best bone that there is, because I don't care how good we are as dentists, we'll never grow bone as good as what that patient started with.
That's right.
So yeah, these are the kind of things I think about, but highly sintered products, getting back to your question, have a tendency to have a higher percentage of encapsulation than products that can be broken down readily.
Yeah, and I've, as a restorative dentist, I've taken healing caps off on impression day, and you'll see these this scattering of tiny little particles of basically they're little rocks in there that never really went anywhere.
And that was one of the things. Yeah, sorry. Go ahead.
Go ahead.
Sorry about that. Oh, I was just going to say that was one of the things that kind of got me away from xenograft grafts initially early in my career, because I was coming back 6 months later and opening things up, and then you start to drill an osteotomy and there's just stuff coming out. You can't get good primary stability because you can't drill a concentric hole. It just was a problem. And I really didn't know what the reason was, because I was, I guess, either naive or you only know what you know. No one ever really talked about those things.
And I wonder, as you were describing that connective tissue being in there, or that implant, maybe it's not as integrated as we think it is. I don't know if the devices that people use to test integration, to get these readings, if they're getting to be more sensitive to that over time.
Possibly. Possibly. I mean, but the thing is, RFA could still, using an Austel or a Penguin or something like that, you're still going to get a high stability reading because you're still up there, and you'll still get 70 plus and think everything is fine. But that is taking kind of a minimal reading of side to side movement, and it doesn't really take into account the type of load that's going to happen once it's restored, right?
Yeah.
Especially in a molar or even an anterior tooth, because an anterior tooth, the majority of the load that it's going to take is going to be off axis. And if I think you can easily overload. And it's the tendency also of a patient to get a new tooth and want to use it. Right. And so, I think it's interesting because I have, taken ISQ values and they're high. And then down the line, it still fails under load, because there's a big difference between the amount of force, so to speak, that an ISQ reading is taking versus 250, 300 PSI for a guy in a posterior. So, very different.
And so maybe as that plays into implant failure, we need to be even more cognizant of the load that we're allowing to be on these teeth to begin with. I mean, I heard a prosthodontist once describe implants more as placeholders than as functional teeth in the way that we think of the rest of the natural teeth.
Yeah, I think, obviously from a restorative point of view, there are things that you should take into account, that you're not necessarily restoring these the same as natural teeth. And I don't really subscribe to smaller occlusal table, which was very in vogue for a long time.
For a while, yeah.
What I try to do is I try to minimize forces by very shallow cusp angles on my restorations. When coming across in lateral movements, I try not to guide off of my implant. I want it natural teeth to guide and just slide right over. And my occlusion is very light from an occlusal point of view. Usually what I'll do is I would have the patient go ahead once the restoration's in there. I'd have them bite down, squeeze as hard as possible, and I would adjust back until I just barely had contact in
Yeah.
the occlusal. Because the last thing you want to do is you don't want your implant to be your vertical stop. That's a
Yes, that's the
disaster waiting
worst.
to
Yeah.
happen.
Yeah.
Yeah.
Yeah. Something will
Also, too,
fail.
yeah, and it's difficult sometimes when, like, for example, like you're restoring a canine, and you want it to look good, but canines are designed to be
Yes.
guiding cusps, right?
Yeah.
So,
And
yeah, I'll talk to a patient. I'll say, hey, we let's change what the one on the other side is a little bit, put them more into a group function. But what I don't ever want to do is I don't want that single canine to be my guiding,
yeah.
guiding cusp in excursive, because it goes downhill.
Yeah.
Yeah,
It'll lose every time.
yeah.
The Osteogen plugs come in three different shapes. I guess, well, plugs is one of the shapes, but there's plugs, strips, and blocks.
Yeah.
Obviously, they've designed three shapes for a particular reason. Just take me through. We talked a little bit about the plug, obviously, as a socket preservation vehicle. Where are blocks and strips best utilized?
Well, yeah, I mean, so it was all designed to be site specific and to address specific clinical situations, right? So, yes, the plug was designed as a socket preservation, one step, one plug, put it into the
Yeah.
hole. We started very early on. A lot of us started to use those plugs, cutting them lengthwise and shoving them down in the gaps that were created in immediate implant placement. And then we started, we talked to the guys at Impladent, and then the strips kind of came about with that. And the strips in my hands are what I did go to for grafting around implants when I'm doing immediate placement. Just because they're flat, usually your gap is 5 millimeters or less for the most part, unless you're doing a big molar. And so in that situation, we would cut the strip to the appropriate size that we need. What I like to do is to hydrate those first to make them more malleable rather
Yep.
than waiting and allowing the socket to do that. So rehydrate it with either sterile saline or draw patient's blood from the socket. There are practitioners that do PRF and add PRF to it. But for the most part, the simplest way is sterile saline or your blood from the socket. Put it into where the gaps are going to be. And the nice thing about that material is now when you drive your implant in place, so we'll put those in first, drive the implant, you're never going to have to worry about your graft material preventing your implant from seeding,
Yep.
which has happened to me with particulates before, that I kind of scrape one wall, push a bunch of particulate down past the nose of the implant. And now once you drive it down at the end of that osteotomy, you end up blocking yourself out. With this, what happens is the collagen and the crystals, basically that whole structure will three-dimensionally fill your gaps. As the implant goes in, it'll kind of move it around and laterally condense it. By the threading it, basically the excess comes upward. Then I usually will pack that back down over the platform of my implant, drive my healing abutment on top of it if I've got good primary stability. If I don't, then a flat cover screw, close things up. So the strips work really well for that. The strips work well for onlay grafting.
Okay.
If you've got situation, let's say you have a dehiscence and
Yep.
you decide to go ahead and place an implant, or you create a strip perf by your implant placement, then you can use that very easily to graft that. And then the blocks are really nice when we look at grafting in the sinus, especially lateral sinus approaches, because it's a larger block. It's going to take up more room. The plugs are actually, the apices of the plugs are cut off and used for vertical sinus lift. It's a great graft material for that because you don't have to worry about migration. You don't have to worry about if you have a small
Yeah.
perforation. It's all self-contained. And then the blocks are really efficient for larger defects, like what I call those catcher's mitt defects. You've got 2 or 3 walls already there.
Yeah.
They work really nice and to go into those sites. You still need to manage the compression of the soft tissue. you're still going to want to use a membrane in some way.
Yeah.
So in situations like that with larger grafts where I'm trying to build out a ridge and I don't want collapse, I'll usually incorporate something like a PTFE membrane that's reinforced with titanium. That way I can resist the forces. Sometimes I've used tenting screws for that situation. I try to avoid mesh when I can, just because I personally have just had bad experience with mesh over the years, and I prefer to not have create more problems for myself.
Yeah.
But yeah, these products were designed in such a way by people way smarter than me to really address clinical situations efficiently. And I think that's where it really came down. A lot of specialists use these products, but it was really initially designed as a GP grafting option that was going to be efficient, it was going to be easy to use, and it was going to be predictable.
Yeah. And for the people that have not experienced osteogen at this point,
Mm-hmm.
how do you coach them to help them believe that it works? I mean, I think you have kind of two different camps here. One would be somebody that's not done any grafting at all, and then you've got somebody that's very experienced and they're comfortable with what they use, and they say, "Hey, this works for me. I've been doing it this way for so long."
Yeah.
On and on. But how do you convince them to open their eyes to other possibilities?
Yeah, it's actually kind of two different approaches. If we're looking at the approach to talking with an experienced practitioner,
Yeah.
usually what I will do is I will ask, what current materials are you using?
Mm-hmm.
And what issues, if any, are you having with them? But they may come back and say, you know what, I'm using a particulate and a membrane, every socket preservation, and I don't have any problems. At that point, I'll say, well, that's great. And here's another alternative that you might have that you can use, and to look at the osteogen materials, the composite plugs, or if we're talking about that, as your graft material. It's a replacement for your particulate. And if you really believe that you have to have a membrane on it all the time, I'm not going to try to persuade you from doing that if that makes you sleep better. But we have clinical evidence that shows that in a fully intact socket, that we can do a socket preservation without the need for an additional membrane and get the same results or better.
Yeah.
And so I usually will tell them to try it, right?
Mm-hmm.
The easiest thing to try is a socket preservation. And then they can kind of move on from there as they become comfortable with the material to use it in other uses. With a new to grafting individual, I try to focus more on technique with them to get them to understand that this material, just like any material that we have in dentistry, only works if you follow the directions. And we as dentists, we think we know better most of the time, right? And I think I've never opened up an instruction for anything, and usually, you make a mistake and you go, there it was written right there.
That's right.
So what I will say is, for this to really be successful, what you need to do is obviously get that tooth out as atraumatically as possible, as we've mentioned before. Establish a good blood supply. This is going to be key. It's going to be key with no matter what graft material you use, but it's extremely important with plug style grafts that contain collagen, because they're going to suck blood into it. If you have a site that's not really bleeding and you put a dry plug in there, it's going to essentially clot up whatever's there on the walls. Your plug then may get dislodged, and then the patient ends up with a dry socket situation.
Yeah.
So we want to try to avoid that. So we need that constant blood flow, which is also going to help feed our ability to regenerate bone. And then place the graft as you're instructed, and then make sure that you can suture it so it doesn't move around. Key to any grafting is you can't have your graft move, and you can't have what you're grafting against move. So everything has to be stable in some way. And then if you can do that, I say start off with socket preservation. It's the not only the simplest type of graft to do, it has the highest percentage for success.
Yep.
And even if it doesn't succeed, you're better situation than if you did nothing at all. And so, see how it is. I recommend them to take an immediate post-op x-ray to see what it looks like when it's fresh in the socket, and then be able to compare those two x-rays side by side 3 to 5 months down the line, and to take it slow. And I think the progression is socket preservation. And then as you move on from there and you become more comfortable, then you can move on to other things. Experienced clinicians, I still say, start with the socket preservation, prove to yourself that the material works, and then you're going to realize what you can use this for. And that was how my kind of evolution was, wow, if this works here, why can't I use it someplace else?
Yeah.
And so I started with socket preservation and moved into using it in the sinus, both vertically and laterally, using it in larger defects, using it around implants when placing. Basically, in my practice, I had essentially replaced all my other graft materials, except for large ridge augmentations.
Yeah.
Larger ridge augmentations, I think, benefit greatly from materials that take longer to break down because they're going to hold space better. But we've got a lot of practitioners that utilize PRF with these products, doing ridge augmentations, and are very successful with it. But that's because you're supercharging this product when you're adding in biologics.
Yeah. Before we close out, I wanted to have a little bit of fun still on the topic of implants here, because I know you've been around every implant company under the sun to some degree. I've always wondered if there's any logic to why I have probably 6 or 8 different screwdrivers, because all of these companies have different heads on their screws. I don't know why the implant companies couldn't have signed a truce a long time ago and just agreed that Phillips head would be the best way to go. What are your thoughts on this screw head nonsense?
Oh, I'd agree with you 100%. I don't know why it didn't just become, this is an ISO standard, right?
Yeah.
ISO standard is an 050 hex or whatever whoever decided to put it into play. I think it's like anything. It's you're going to have different driver types because you're forced then to buy the product from that company. I think it's no different than, in the automobile industry, when Mitsubishi first came to the US, Mitsubishi had their bolts and their screws had a proprietary size that the only way you could buy those drivers was you had to be a certified mechanic through Mitsubishi. Right. And that was why Mitsubishi had a really difficult start. And then they finally went, okay, this is crazy. We'll just go ahead and use metric bolts. I don't know if you read recently, BMW now they just got a patent on a new bolt head that it looks like the emblem. What does that mean? It means that they're going to change all their screws. Nobody's going to be able to take the cars apart unless they can buy their driver. Yeah, so I understand from a point of view of business, you're going to force your clientele to buy your stuff. But I agree with you. It's where it becomes frustrating with that is when you have a patient that comes in and you have no idea what that implant is, right?
Correct.
It may be, an older implant. Maybe it's an implant that wasn't sold here in the U.S. And literally you can mess things up badly if, it looks like a hex, right? And you put in an 024 instead of an 027, and now you destroy that, right? Yeah. That's where it is. When I think the greatest product that ever was made was when somebody came up with that kit that has all the different screwdrivers in it. But many times it's a matter of, okay, I'm going to put it in. I'm going to feel, no, that's not it. That's not it. That's not it. Why it's not standardized, I don't know. I don't think that there's any advantage from one driver over another driver. Not at all. Like there really isn't.
Not more secure or anything like that.
But to follow up on that, just if you're really interested in things like that, there's a really interesting book out there that's the history of the screw.
Oh,
and
I'll have
it
to check
and
that
it
out.
goes and it goes through the history of the fighting that happened between straight blade, Phillips head, Robertson head, and
Wow.
how they, I mean, it was massively in the Industrial Revolution. It made companies or broke companies, and it's all about that head and
Yeah,
what you can have. So yeah, it's an interesting read if you ever
I will
jump into that.
I will definitely check that out. The other topic that I wanted to hit on is whether the category of implant dentistry is creating its own crisis in how frequently we change designs. Because now we've got literally millions of restored implants in the world and
Uh-huh.
more every day. But we all know the reality of a crown that might be 20 years old. And I see them in my own practice where the person comes in, they had an implant crown done 20 years ago. Maybe it's a
Hmm.
PFM on that implant. They've broken a huge chunk of the porcelain off, and it's enough that we now need to replace their crown. But it takes us down this rabbit hole of, do you have any idea what the implant is? Can we even still get the parts? So if I want to make
Right,
a
right.
new crown and I'm going to do a screw retained crown, can I get the impression post? Can I get a scan body? All of these things. And I don't know if the implant industry is prepared to address that, or they're just leaving it to some third party company to come up with these legacy parts, if we want to call them that.
Yeah, I think it's the latter. I
Yeah.
think that there are a lot of companies that have made minor changes and then they have continued to have product,
Yep.
whether they are actually manufacturing that product or it's whatever stock was available at the time. And when that's gone, it's
Yeah.
gone.
Yep.
I think it becomes even more difficult with smaller boutique implant companies that may have proprietary connections. But again, just like the driver aspect, it would have been really nice to have some agreement across the board.
Yeah.
But I don't think you would ever get that because I think that the argument over the advantages and disadvantages of different connections drives
Correct.
drives the implant companies, right? But I agree with you. I think it becomes a problem, and it's going to continue to become a problem
Yeah.
as some of these connections disappear, like they already have. And as you said, no third party there. It doesn't make good business sense to make 500,000 connect abutments to fit this connection
Yeah.
when you have no idea if half of those are going to be need to be replaced. So yeah, I don't think there was a lot of forethought into that. I don't think anybody really thought about it. I think it's becoming more of a I think now it's more of a problem because we've got 40 plus year history of implants being placed,
Yeah. And I
right?
and I wonder if there's an
Yeah.
opportunity for a company to say, in some way, our parts will be forever available. By that I mean,
Mhm.
with advances that there are in manufacturing, companies could produce one-offs now and again as they need to, at not a great expense, because they're able to machine these or 3D print them or things like that. And almost, if there's this, if there's assurance that you could always get parts whenever you need them, I might be more
Yeah.
loyal to a brand like that than knowing that one day I might call. And like you said, I've run into this where you call about a legacy implant and they say, well, whatever product we have on the shelf is what we have. Let
Yeah.
me go and look and see if we have the part you need. And if we don't, I'm sorry, we don't have it. I mean, that's a terrible spot to be in.
Absolutely. And what would be nice is if there was some way that, for example, you're a specific implant company and you phase out a connection, or you've got connections from the past that have already been phased out. They're 20 years behind the time. It would be really nice that if you as a company are not producing these parts anymore,
Yeah.
that you make public
Yeah. That design.
the STL file of that
Yeah.
design, right? Of that connection. Because then with technology today, it can either be milled or it can be 3D
Yeah.
printed.
As long as the lab
Yeah,
can access that, they could
yeah,
make a custom abutment, et cetera.
right. And you just have this big database that every company is, and it should be a regulation that every company has to dump into it in order to not leave patients stuck.
Yeah.
Because I can't believe, and I don't know 100%, but I would assume if you had a prosthetic hip or knee done 40 years ago,
Yep.
and things have changed, that there's still a driver out there to get those things out or to do revisions. Maybe not. But I think with implants, it's very different because we know that things aren't going to last forever.
Right.
That they're susceptible to breakage. And as I said, now we're running into a problem where we're 40 years into this, and we also have patients that are living longer. So now we've got these implants that might be 50 to 60 years at some point, maybe longer, and they're just not going to survive. And good luck finding parts. I mean, I've run into the same situation where we had a patient that had integrated implants on the bottom that were done back in like late 80s, and trying to find prosthetic parts to fit was so difficult, and we ended up not being able to do what we wanted to do because we couldn't find the parts for it. And we had to do a secondary type of treatment that worked out, but it was very expensive, very difficult to do. So if it was a situation that, hey, you're phasing something out, that means that the clock ticks. You have to give all that information up, so that way it's available for the next generation of dentists that have no idea what they're looking at.
Yeah, I love it. Well, Charles Schlesinger, I want to thank you so much for your time today and your expertise. I really appreciate it.
Well, thanks for the opportunity to be on. Always a pleasure to talk to you, and call me up anytime.